ठीक है. Assalamu alaikum. Good evening, everyone. I welcome you all with the greeting from Dr. Sharjeel for giving us his valuable time tonight to discuss very important topic of eye-related issues. And welcome, sir, for your time. Thanks a lot. And it's very pleasure to have you at night for discussing this important topic for our patients and for our young doctors.
Thank you, Dr. Adnan, for your precious time. I am also grateful.
It's my pleasure, sir. Today, sir, we are going to discuss a very important topic for a patient point of view and for doctor's point of view. First, I would like to discuss with you about what is squint and how can we define a squint in perspective of patients as well as in doctor's perspective.
Well, definition is quite complex, but to make it simple, we would like to say that misalignment of the eyes is called strabismus or squint. When the two eyes they are not aligned on a object of focus, then it is called squint. So, for audience, for layman, we should keep it to this definition.
Thank you, sir. Means if eyes are not straight, then we can call it a squint.
Yes.
So, speaking generally in broad term, what are the types of squint?
Well, squint can be divided under many schemes, like the type of deviation, like it can be divided according to the type. If the eye is inward, then it can be called esotropia. If the eye is outward, then it can be called exotropia. If the eye is upward, then it can be called hypertropia. If the eye is downward, then it can be called hypotropia. So that's one classification according to the deviation. And the other one is according to that whether the squint is due to paralysis or non-paralysis. So squint can also be divided into paralytic squint as well as non-paralytic squint. And then we can divide it into congenital and acquired squints. Then we can also divide squint according to etiology, like traumatic squint or due to other syndromes like restrictive squints. So there are many classifications of squint. Then it can be alternative squint, when one eye is straight and the other eye is either in inward direction or outward direction, and after some time the other eye fixates and the first eye becomes. So alternative squint or unilateral squint, intermittent squint or constant squint. So there are many types of there are many ways through which we can classify squint.
Thank you, sir. Sir, is it possible that patient seems to be normal, but sometimes it manifests the squint and sometimes it don't manifest the squint, that we also call in ophthalmological terminology as phorias? Can you please tell us about that disease and that particular pathology?
Yes, phorias definitely. Phoria is a squint that is a latent squint. It means that it is hidden, and most of the time the eyes are straight, but sometimes the patient will tell you that he feels that on occasions one eye that deviates, but when you examine the patient, the eyes will be straight. So the squint can also be divided according to latent squint and manifest. Manifest means that the squint will be present all the times when you examine, whereas for latent you have to perform cover and cover, alternate cover, prism cover tests in order to make it manifest. So yes, that's also a very important type of classification, manifest as well as latent.
Thank you, sir. Sir, our next question is the squint treatable disease or it's untreatable? Because in layman terminology and in common people, it's a perspective that squint is untreatable and it leaves with the it resides with the patient's age till the patient is ages and it resides with the patient. So is this a misnomer or is there any treatment of squint?
Well, there are many myths that are attached to the squint, like people, they don't have a background of squint, and they will just make their mind that a squint is an untreatable disease. But squint has got complete treatment, and its treatment is also manifold. Like a few squints that can be corrected with just spectacles with refraction, some squints that can be corrected with exercises, some squints that can be corrected with prisms, and some squints will require amblyopia therapy, and some will require surgical correction. Also, we can have these paralytic squints that can correct with time. So squint is totally a treatable disease, and there are many myths attached to it that it's an untreatable disease and there is no treatment and you have to live with squint for the rest of your life. And another most important thing I would like to mention is that many patients who come to me, and definitely they will be seen by you, that they are told that when they present to the treating physician or ophthalmologist or optometrist or any eye care professional in early childhood, then they are told that you will be treated when the child becomes 10 years or 12 years of age. So that's totally untrue thing. And the squint is a disease which, if presented early, has more chances of success when you treat it in the early visual development stage, in compared to when patient has a squint, for example, at the 2 years age, and it is delayed for 5-10 years. So the amblyopia that can become dense, and the squint can be difficult to treat in adult life, the childhood squint. So main important thing is that this is a myth that like in our language, the father will tell you that डॉक्टर साहब ने कहा कि बच्चा अभी छोटा है, तो जब ये बड़ा हो जाएगा तो फिर इसका हम इलाज करेंगे. So this is a myth, and after 1 year of age, squint can be treated with all the above things which I have told, with spectacles, with refraction, with prisms, and with surgery.
Yes, sir. This is my another question I would like to ask. What is the normal age for development of the visual alignment, and when one should think for the management and operation or other optical management of a squint? At what particular age it's normal to have somewhat underdeveloped alignment or center of alignment, and at what age we should go for management and treatment for the squint?
Well, I have already answered you this question, but once again, I would like to narrate a few practical examples as well. Like few days ago on a forum, a doctor presented a case that there was a patient with deviation of the eyes, and the baby age was 1.5 months. And he said that should we go for cycloplegic refraction. So I told him that any deviation before the age of 4 months is irrelevant, because the visual development is in infancy and it is going on, and we should not take any deviation of the eyes seriously before the age of 4 months. But if the deviation persists beyond that age limit, then we should take it, because one of the common congenital esotropia, essential infantile esotropia, it presents at the age of 6 months or more. So after the age of 4 to 6 months, we should do cycloplegic refraction, and we should see that whether the squint, the patient has got any refractive error or not. We should treat it, and then definitely there are other clinical examinations like in babies we need to check the extraocular movements, the preferential looking of OKM with OK and drum, that whether the fixation is steady and maintained. So all these things, if the vision is good, then we can follow the patients. But the surgical treatment of the squint can be done after 1 year of age, and the visual development occurs. It occurs after birth and up to 5 years of age. So if we correct the squint within this age limit, then there are more chances of developing stereopsis and binocular vision. If we delay the squint management beyond that period, then sometimes we get a crude vision. We can get a patient 6/6, but stereopsis and depth perception is crude in those patients.
Thank you, sir. So this is very important concept that you have highlighted, that till 4 months this is irrelevant to be worrisome about the any misalignment in the baby. But if it's beyond the 4th month, then we should be kind of consider to evaluate the patient for regarding any misalignment, and after 1 year we should go for a surgical operation for the management of squint, and till 5 year the visual maturation or visual development is occurring. So this is very important concept. Thank you for highlighting this. So second thing I would like you to answer, what is the connection between squint and amblyopia?
Well, as we all know that amblyopia is called lazy eye. Even today, I have, as you know, I have got my YouTube channel Sharjeel Eye, which has got almost 25,000 subscribers and almost 1,800 videos related to the eyes. So today, I presented a video on complete full-time patching therapy of amblyopia. And I presented a patient which presented last month, and his vision was counting finger. So he had a dense amblyopia, but the age was 7-8 years age. So it's a very good age if you get amblyopia patient, because the vision is totally reversible. And after 1 month of complete patching, 1 month or 40 days of complete patching means 7 days a week from morning till night, the patient vision improved from counting finger 2 feet to 660. So that's a remarkable improvement in a 1 month time. So one of the type of amblyopia have got many types, different types, and one of the common amblyopic type is strabismic amblyopia. The eyes are straight. The eye is straight when it sees, because the mind, actually the anatomical position of the eyes is a little bit exotropic. Do you understand?
Yes, sir.
The anatomic position of the eyes are little bit exotropic, but our mind, our brain, our visual areas in the brain, they keep the eyes straight and focused. So our eyes are straight. In amblyopia, there is a decrease of vision. So that decrease of vision lead to the eye to become either esotropic or exotropic. So when we get a strabismic amblyopia, we have to check whether it's a pure strabismic amblyopia or there is an isometropic element as well. Because if there is an isometropic element as well, then first we treat that component. If there is a refractive error, we have to correct it, and then we have to give him patching, and the eye will become straight. If there is no refractive error and the eye is amblyopic and deviated, then we have to surgically align the eye and also give patching. So in this way we treat strabismic amblyopia, and one of the commoner types of amblyopia is strabismic amblyopia.
Thank you, sir. So another my question is, for example, this is all what you're saying for the eye which are still in development or maturation, visual maturation and alignment is still occurring. In adult life, for example, if anybody has got any strabismus and that leads to an amblyopia, so after a dense amblyopia patient is adult, is it possible that we offer some treatment, surgical treatment for alignment of the eye, or is there any worth, or it's not useful?
But not only amblyopia, but generally, if you generally when a patient of squint present to us, the most important test is not to measure the deviation. The most important thing is to measure the visual acuity. If the patient have got even 100 prism diopters deviation, but vision is 6/6, then there are more chances that when we surgically align the eyes, they will be straight forever. But if the patient has got a mild deviation, but his vision is counting fingers or hand movements, then the prognosis for the surgery is poor. So vision is an extremely important thing, and definitely when the vision is poor and the eye is deviated, so there are more chances that the patient is also having amblyopia. So in those patients, when there is amblyopia as well as deviation of the eye, first we treat amblyopia with complete patching. Even I have treated amblyopia up to 30 years of age. So whenever a patient of 17, 18 years age patients, they present to me, and when I told them that let's start full-time patching, then they get surprised that we went to other eye care professionals and they said that now you are old enough and your vision cannot be improved. So, but when I tell them and they start it and then they get improvement, only then they believe in me. So the thing is that first, if the patient vision is improved with amblyopia therapy in adulthood, sometimes the vision didn't improve. So if the vision didn't improve, then you can tell the patient that I can surgically align the eye, but there are more chances that it can go back and the misalignment can occur again. If the amblyopia therapy works, vision improves, and vision improvement, a very important point is that you don't need to improve the vision up to 6/6 level. Understand?
Yes.
Like if the patient present to you with counting finger vision and you improved it up to 6/36, 6/24, so that is also a very useful vision. And at that vision, if you surgically correct the strabismus, there are very less chances that it will go back. So all these points you have to consider in adults with amblyopia and with strabismus, and with experience you titrate these things and treat the patients accordingly.
Thank you, sir. Next question comes that regarding the surgical management of squint, as I have in most of our practice, we usually do in general anesthesia. But recently, I have seen your post that you have operated a squint patient in local anesthesia. I would like to ask your experience and pros and cons of operating squint in local anesthesia.
Well, definitely, I will give my. I perform almost 95% of my squint surgeries in local anesthesia with very good results, and I will give my credit to my supervisor, my mentor, Professor Imran Akram Sahaf Saab, who is a legend oculoplastic surgeon, a leading oculoplastic surgeon in Pakistan. a very well-known figure. You must know him.
Yes, sir.
So we have done training with him. We have seen him, and he used to operate patients as young as 12 years of age in local anesthesia. So definitely I don't treat at young age in local anesthesia, but if the patient is 15, 16 years old, and he or she is brave enough, I told them that I explain the whole procedure. I tell them that local anesthesia is far better than general anesthesia. The complications of local anesthesia are less, but you will definitely feel some pain. So almost all patients, they agree to local anesthesia because they are awake, they are aware of the situation. And the other thing which the general anesthesia people, they say, why we do, the most important question is why we do squint in general anesthesia. Do you know the answer to this question?
Sir, yes, because it's a long procedure and we need a complete akinesis of muscles, and it will for surgeon's point of view, it's more convenient to operate in general anesthesia because sometimes local anesthesia doesn't work. It can lead to a retro. We need a complete akinesis to manipulate muscles, and we need to for example, if the local anesthesia there is still some sort of movement, it's not completely kinetic. So that's why I think we need a general anesthesia.
Well, you are up to some extent you are very right, but I would like to add that in a general anesthesia, the patient is asleep and he is not able to contract his muscles. Understand?
Yes,
they are completely relaxed. Patient is pain free. Patient doesn't know about any pain. The surgeon is comfortable because he is able to stretch the muscles at ease. So the surgeon is comfortable, patient is pain free. These are the two most important aspects of general anesthesia. And definitely you are also able to see the dreadful the heart rate, that if there is a worrisome bradycardia, you can treat it, the oculocardiac reflex.
Yes, sir.
So these are the pros of the general anesthesia. But as I am doing the squint for 6-7 years continuously under local anesthesia, definitely in local anesthesia we also attach monitor and we monitor the heart rate. But definitely in local anesthesia the surgeon should be experienced, because sometimes the patient will experience pain, especially when we manipulate medial rectus. As I do vertical as well as horizontal squint surgeries, I know all the muscles. I have encountered significant bradycardia with manipulation of medial rectus only. None of the other 5 extraocular muscles, the patient will get worrisome bradycardia. So the thing is that while manipulating medial rectus in local anesthesia, you should be gentle. You should keep an eye on the monitor heart rate. You should keep ready the atropine. So if there is significant decrease heart rate, you should inject atropine. But so far I haven't seen any patient that have got complication due to oculocardiac reflex. The other thing is that that as you mentioned that it is less duration, the local anesthesia. So for that you must know that we have got long-acting local anesthetic bupivacaine as well. So if you mix half bupivacaine plus like 2.5 ml bupivacaine plus 2.5 ml xylocaine plus adrenaline. So that works wonderful for 30, 40, 50 minutes. And with experience, like now, 2 muscles, I do it in 15 to 20 minutes. So I have not done except transposition of muscles. When I perform transposition of muscles, I also perform it in local anesthesia. So that procedure is almost 1 hour long, because you have to transpose the muscles in Jensen's and emulsion procedure. In other procedures, if you have to perform 2 muscles or 3 muscles, it will take 30 to 40 or maximum 45 minutes. So if you inject bupivacaine, the effect will be there. And the other thing is that little effect is better, because most of the time when we complete the surgery in local anesthesia, the patient is able to move the eyes. So we remove the upside and we check the alignment as well on the OT table, that the eyes are aligned, our calculations were okay, or there is little bit under correction. So at that time we can manipulate further. So local anesthetic have got advantages as well.
Sir, I would like to ask which method you adopt for injecting local anesthesia. It's peribulbar or retrobulbar?
Well, I perform peribulbar. I perform peribulbar, but I would like to tell you almost 2.5 ml superiorly, 2.5 ml inferiorly. Not all the 5 ml inferiorly like most of us do. Plus, I also inject 1 ml at the facial.
Okay.
So 0.5 ml at the upper margin of the lid and 0.5 ml at the local margin of the lid, so that the patient doesn't squeezes the eyelids, as well as superior and inferiorly all the muscles are anesthetized.
Sir, another question I would like to ask which type of incision you usually adopt while doing conjunctival dissection? You do a limbal base incision or fornix base incision, and what is your experience in your method?
Well, the thing is that I go from limbus,
okay,
in a V-shaped pattern, and I have also done surgeries in which I have given incision just on the insertion, a muscle insertion.
Yes.
But I am more comfortable when I go from limbus towards the muscle in a V-shaped pattern.
Okay. So you and while attaching a muscle to the desired or to the targeted location, you usually adopt which technique of suturing? You do a adaptable suture, or or you
adjustable
suture, or you just like do what a conventional method of attaching it, and or any other method you adopt for tying the muscles?
Well, most of the time I perform permanent constant sutures, but sometimes if I am unsure about the calculations, or if there is a variation in the squint on measurements, then I also perform adjustable. But most of the time I perform permanent constant sutures.
So, sir, in your experience, which is
yes. And I would like to add one thing as well, that I don't perform the scleral bite procedure, recession. The conventional recession I don't perform. I perform hang back technique.
Okay.
You must have seen my videos on YouTube. So in all my recessions from 2016, I have not passed a scleral bite.
Okay.
So I suspend myself from the stump to the desired level, and it attaches to it. Like the people are afraid that as we use Vicryl, which is a digestible suture,
yes.
So after the suture will be digested, the muscle may slip. Muscle needs 2 days, 48 hours at a place where it sticks to the sclera.
Okay.
Understand? So definitely we know that the suture is there for 2 weeks. So that's more than enough time. So I also perform hang back technique during this session.
That's a very good technique, indeed very safe technique for saving the sclera. Sir, in your experience, what is the any good reason for not doing the conventional old method of recession and adopting this hang back?
Well, when I learned that hang back technique, I have found it extremely useful. Plus, definitely, when you are passing the needle through partial thickness sclera, there is a fear. Though I haven't perforated the globe, but definitely there is a fear in your. There is a chance. There is a chance of a scleral perforation. So if you can avoid it, and the other reason why I do hang back technique, that is that it gives you leverage. It gives you more leverage to suspend it. Like you cannot go too much behind the in conventional method to tie the muscle there. But in hang back technique, you can hang it as far as you desire.
Yes, sir. This is also a good reason for adopting hang back, sir. I would like to ask any of your experience of having a lost muscle, slipped muscle?
No, thanks God, I haven't had any experience of lost muscle, but I have seen my colleagues that they have lost. And other thing which I would like to add, as I have done hundreds of squints, only medial rectus is lost. Okay. Medial rectus is the most bulky and strongest muscle, so it contracts and it goes. So if you follow its sheath, most of the time you will get it, and then you can easily attach it. The other muscles, even if you lose it, they are present there. They don't contract too much and go backwards. So my advice to the listeners would be that whenever you are manipulating medial rectus, you should be very cautious, very careful. You should not lose it. The other thing is that whenever you perform pterygium surgery, always keep in mind that medial rectus is just beneath it, and don't cut medial rectus, because I have seen an incident which I have mentioned in my next book.
Yes, sir. I've read it.
Pterygium surgery.
Yes, sir.
During pterygium surgery, one of my colleagues, she cut the medial rectus. So during pterygium surgery, also keep care of medial rectus, and during a squint surgery, keep too much careful and cautious while dealing with medial rectus.
Yes, sir. Indeed, sir. But for example, if any of our colleague or even us, anytime, God forbid, if we lost any muscle, so what should be done, and how can we manage at that time? What should be our steps?
Yeah, that's a very good. Yeah. First of all, you should not become nervous. You should not panic. It's a known complication, and people have lost muscles many times. So it's not a sin that cannot be reversible. Try very gently, because if you manipulate too much, you can also damage the optic nerve or medially ethmoidal sinuses. So try, as I have told you, try to go in the direction of the sleeves, the sheaths of the muscle, and gently try to retrieve it back. If you are unable to it, don't worry, don't manipulate too much, just close it. You can perform MRI of orbit, and that can also guide you about the muscle, and at that time the muscle is contracted and it is retracted back. But if you then again reoperate it after few days, then the muscle will be little bit in the front, and if you perform MRI, that will also give you the exact location where it is, so that you can retrieve it from that position. So MRI can be done.
Yes, sir. Thank you, sir, for this useful tip. And I would like to also ask, sometime it's also happen after surgery, the eyes is still deviated. So, what you suggest for that in that particular case? What should be our approach?
Well, the thing is that miscalculations occurs with me as well. Under correction is a very common complication of squint surgery. Over correction is very rare. So if under correction occurs, you can also take help of the other eye, one muscle, and you can also manipulate the two muscles which have done. But it is better that you don't manipulate those muscles which are already recessed and resected, and go to the other eye, because eyes they work in a unison. So you can recess or resect the other eye, one muscle, and the eyes will become straight. We have got 1 minute, so
yeah.
if you have got last question.
Yes, sir. Another useful tip, sir, you would like to advise us regarding a squint treatment or a squint evaluation or any management surgical tip?
Well, I would like to say that someday we would also like tell you about the pathophysiology or diagnosis and treatment with the Sahaf triangle. My mentor has devised a plan with Sahaf triangle, that there are central lesions, sensory pathologies, and motor pathologies. If you know this triangle, you can diagnose any squint, and you can treat